Using cultural intelligence to improve patient care. Adapted from an article by Pedersen and Stern. In a Boston emergency department, Mr. A 63-year-old Nigerian immigrant, was brought in agitated and confused. He had high blood pressure, was in a febrile, and during evaluation stated, "At my church, I'm the Pope." The team diagnosed him with acute mania and prepared for psychiatric hospitalization. What was missed? Mr. A wasn't delusional. He felt disrespected and dismissed by his care providers. He used a metaphor common in his culture, explaining his role as a spiritual leader in his church to tell his care providers that he was a respected and knowledgeable member of the community. A Nigerian psychiatry resident later clarified this with his family, and the diagnosis changed. His altered state wasn't mania, it was hypertension-induced. This case is a masterclass in how cultural intelligence could have changed everything. Let's break it down through the 4 factors of cultural intelligence. Factor 1, motivation. The inner desire guiding us subconsciously when approaching a patient plays an important role in patient outcomes. Are we approaching the patient feeling tired and ready to go home? Or are we coming with a desire to know the patient, assess accurately what is happening, and understand the context of their arrival to the ER or the hospital stay? In this case, his first providers didn't ask about his cultural or religious role. Motivation starts with a desire to learn to grow, curiosity, humility, empathy, and love, all of which will lead to the desire to know the patient and to get accurate, contextual, and complete information for the correct diagnosis. The second factor is cognition and emotion, being aware of what we are thinking, feeling, and learning. Understanding how mental health is expressed across cultures is critical, especially in the ER. If we don't consider that a patient may be viewing the world through a different cultural lens, we won't look for the signs that matter. And if we're not emotionally self-aware, we may not recognize how our unconscious biases influence judgment. In the case of Mr. A, without awareness of the Nigerian culture's language variance, the well-meaning clinician misinterpreted the patient's sense of disrespect at the ER as grandiosity. This cultural misread was an error rooted in misunderstanding, not malice. The third factor is metacognition and meta-emotion. The discipline to pause and self-examine, why am I thinking what I am thinking, or why am I feeling what I am feeling, will help us quickly overcome looking at a diagnosis from a familiar frame and explore other frames. It will also ensure that we identify our biases and overcome them quickly. Mr. A got lucky that a Nigerian immigrant was the senior resident who understood their culture and could help other care providers tap into their metacognition and meta-emotion skills by asking again and checking assumptions. The final cultural intelligence factor is behavior. Behavior includes how we communicate, make decisions, and collaborate with patients. The senior resident changed the plan. He adapted and helped others adapt based on insight and clarified intent. Because of this resident's culturally informed behavior, Mr. A avoided unnecessary psychiatric treatment and what could have turned out to be a traumatic ER experience. When we combine medical skills with cultural intelligence, we equip ourselves to provide the best care we can. Cultural intelligence saves lives. Let's lead with it as a team.